presentation. Yes. So my topic will be on HPB ERAS guideline, improve outcome. I think you have data from the previous speaker showing that the ERAS improve outcome of HPB surgery. So my talk could be very short, but I will try to be more critical about the ERAS, the data, and finally maybe try to convince you of its necessity and its efficiency. So we are going to look to the guidelines, to the outcome, and is it really improved? You know, ERAS' objective is to improve the quality of care. Patient is part of the process. We aim to reduce the perioperative stress and complication, and then secondary outcome is length of stay, health cost without increase in readmission rate. The concept is perioperative multimodal care pathway, aiming to early recovery, re-examine traditional practice, and in all guidelines, it said that it's evidence-based, and we will come back to this point. It covers all area of patient journey without patient selection, as it has been said before. If you go on the PubMed and you type ERAS guideline, you end with 183 papers. So what is the true ERAS guideline? What is not the true ERAS guideline? You have the ERAS-like, etc. So we have a lot of guidelines and a lot of paper with different items stated under the ERAS. So we are going to look to the ERAS Society guideline because I think, as many, that these are the more efficient and more proven guidelines according to the evidence we have today. First, on the pancreas was published in 2013 and then delivered in 2016. If you look to the level of evidence for the pancreatic duodenectomy, only 8 of 37 items are high-level evidence, it's 22%. For liver, it's only 4 out of 31 level 1 evidence. For bariatric, it's 9 of 44, gastrectomy, 11, cystectomy, 0.1 is high level of evidence. For colonic surgery, 17, and rectal, 9 of 39. So is it really evidence-based? We can ask the question. Liver guidelines were published in 2016. So any paper published before, it's not really ERAS. It's maybe ERAS-like or an attempt to prove some of the care items which were taken later on in this guideline. If we look to the paper, we have 31 items. High level of evidence, only 4. Preoperative nutrition, prophylactic nasogastric intubation, prevention of delayed gastric emptying, and stimulation of bowel movement. Only 4 out of 31 items are high level. And 7 items had less than 75% expert agreement in round 1 and 2 of the Delphi process. So in conclusion of this guideline, that this systematic review highlights that the current available data on enhanced recovery pathway in liver surgery are scarce and lack standardization. So we have to work on this and try to get more proof and high level of evidence of all the items which are stated in the guidelines. If you look to this meta-analysis published last year of 862 records identified, only 4 were selected to be included in meta-analysis. We always compare ERAS to conventional. Length of stay is decreased significantly. Functional recovery is decreased significantly. Overall complication decreased significantly. And grade 2 to 5 complication also decreased significantly. So maybe it improved the outcome. We also look for some data about the abdominal drainage. It has been stated by Nicola that systematic drainage after liver surgery is not necessary. This paper from the Netherlands showed clearly that no drain policy in an ERAS environment does not increase the risk of complication, either overall complication related to the surgery or the specific complication related to the liver cut surface. So the conclusion is that selective no drain policy within an ERAS environment resulted in a rate of post-operative complication, reintervention, and mortality comparable to previously published data. It's not a randomized study. Routine use of prophylactic abdominal drain after liver surgery seems unnecessary. Preoperative fasting, we know that fasting increases the stress and insulin resistance, and the ERAS recommendation is to give oral fluid and carbohydrate load before surgery. These are also the recommendation of the SPAN guideline. So the question is, what is important? Is it the carbohydrate load or the oral fluid? We had recently a meta-analysis published last year, 7,189 records, only 41 included in the meta-analysis compared with fasting. Patients who had carbohydrate before surgery were discharged earlier. Compared with water or placebo, there is no benefit shown for the low or high dose carbohydrate with respect to time to hospital stay. So we have still to work on this to know what is important. Is it only to give water or to give carbohydrate? Question is raised. In the same paper also, they show that there is no complication related to this fluid administration before surgery. No aspiration pneumonitis were reported, and high-dose carbohydrate administration were associated to significantly decrease in insulin resistance compared with fasting and water or placebo. So there might be also benefit of carbohydrate load compared to water or placebo. Intravenous fluid, this issue was also explained previously in the previous presentation. The importance is to have a restrictive or targeted policy. The question is raised. We know that liberal fluid is not good. We have data from GI surgery showing that if you adapt the intravenous fluid on stroke volume measured using esophageal Doppler, you have less complication. This is significant. But this randomized study is criticized because it has major limitation related to absence of blinding and high rate of patient withdrawing consent. So we have still to work on this item. We also know that early oral feeding is beneficial for the patient. These are data from gastrointestinal surgery. These are 15 studies, 8 randomized control study showing that early oral feeding reduced mean hospital stay, and there is no significant difference in complication as anastomotic leak, pneumonia, gastric tube reinsertion, reoperation, readmission, or mortality. For the pancreas, guidelines were published in 2013, so maybe you have more precise data on the pancreas. We have 37 items in the guideline. High level include preoperative fluid intake, antithrombotic prophylaxis, antimicrobial prophylaxis, epidural analgesia, avoiding hypothermia, fluid balance, perianastomotic drain, and suprapubic catheterization. So 8 items are high level of evidence. If we look to the outcome, this paper is published in 2013, so early when the guidelines were published, showing decrease in the morbidity, but the mortality don't change and readmission rate don't change. One of the early paper also published by Braga from Italy, ERAS pathway in pancreatic duodenectomy, they only use 12 ERAS care elements, not the whole ERAS protocol. They show that the compliance is very high, almost higher than 80 or 85%, and most of them nearly 100%. They show that the compared ERAS versus control, they improve the bowel motion, oral feeding, stop IV fluid, and mobilization. However, the same team published more recently, last year, the evidence on patient undergoing distal pancreatectomy. And here they increased the ERAS care element from 12 to 18. And surprisingly, they didn't have any improvement in the outcome. So the question is raised is how we implement the program, how we audit the results, and how the process is all done, because it's surprising that with more ERAS care element, you have no difference between the pre and post ERAS group. If we look to the outcome, if you use some of the ERAS element, what we call ERAS-like, and the full ERAS, you see that you improve your outcome. Before ERAS, Then you do ERAS-like, you have better outcome, and then you do the ERAS program, you have more better outcome for the patient. This recent paper also from China, published in 2016, they show when they compare to historical cohort that the ERAS group have improved outcome in morbidity, in mortality, length of hospital stay, and a good compliance rate for the nasogastric tube removal, oral, liquid, and solid food. Systematic review and meta-analysis, they also show in different type of surgery, pancreatic duodenectomy, total pancreatectomy, distal, etc., that the cost is reduced between the control and the ERAS group. These are data from our center. It has been also shown previously from other, in the previous presentation, that when you use the ERAS program, you improve the patient length of stay. You see, these are the data, before the ERAS. You see length of stay in ICU, length of stay in high dependency, and you see that when you implement ERAS, you have more steady length of stay, you have less variation. And when you look here, you have less patient going to ICU, less patient going to high dependency unit, and more patient going back immediately to surgery ward after pancreatic surgery, even pancreatic duodenectomy. And this is very important for the patient management and the health cost. So how we measure the evidence for the ERAS program? This, you know, all the pyramid of the quality of evidence. If we look to the item of the ERAS guidelines, mostly low level of evidence. Most studies are retrospective and they are before, after. So can we do today a randomized study doing ERAS and no ERAS? I think this is totally impossible. So we have to think about other way to evaluate. We have also to look to secular trend. We know with time, we improve our performance. So this may also impact the outcome, and the improvement is not only related to the change we made in our unit. And we have also looked to the audit and reporting. And about audit and reporting, you have to ask the question, should we have evidence for all what we do? If you look to this paper, it shows clearly that auditing is very important. This paper published this year about the surgical site infection. If you have three ways of measurement, the NISQIP, the administration, and the NHSN measurement, you have only 17 surgical site infection were reported by all three systems. So you see, you start with 130 infection, and only 17 are concordant between the three methods of measurement. So auditing and reporting is crucial in evaluating our results. So should we have evidence for all what we do? I said we have low level of evidence, only few items in the ERAS program. But in the meantime, we see that we have good outcome with the ERAS protocol. Claude Poutot was a surgeon working in Lyon at the Hôtel Dieu. He observed that a lot of patients were dying in his hospital after surgery with severe pain, surgical site infection. So he saw that he may change this. So he asked the patient to come on the day of surgery, to stay as less as possible in the hospital, and to bring their own dressing, not to use the dressing from the hospital to avoid the spread of infection. But he was the only to do this. He shortened hospital preparation, shortened hospital stay, so he get better pain control, better surgical site infection prevention, less patient preparation, and decreased length of stay. He didn't have the proof, but he was right. Ignaz Melwitz, German-Hungarian physician, he was appointed assistant in the obstetric clinic in Vienna in 1844. He observed that they had two divisions for delivery. The first division of the clinic, death rate from childbed fever was 2 to 3 times as high among those in the second division. He observed that the first division, only students were working, and the second division were midwife. And students used to go to the dissecting room, examine women who died after their delivery, and go back to the ward, examine patient, and the woman get infection. So he asked them to wash their hand with solution, with chlorinated lime before each examination. And he reduced the death rate from 18 to 1%. He talked to his chief. He didn't believe him. He started writing to many centers and hospitals all over Europe. No one wanted to believe him. He was in big distress and he ended in psychiatric hospital, and you all know he died, ironically, from surgical site infection after operation on his arm. So we have also to standardize procedure. You know, prehabilitation. Prehabilitation started in UK after the Second World War. Her Majesty Army were recruiting new soldiers, but all young men were weak, mentally not very well educated, high school, etc. So they started a program with better housing, better eating, and sport, and they found that they improved the physical efficiency of these young men and even their intellectual performance. They didn't have the proof, but they found it works. And we know today that prehabilitation is very important. So what are the facts for ERAS? Few items are evidence-based. Many items are theoretical. But the most important is we don't have to look to each item separately. It's probably the whole program which is efficient. And if we look to the definition of fact and theory in science, we know that theory can be true even if never proven. And all we know about scientific theory is that it has predictive power. The only rule is that once we prove a theory wrong via experiment, we know the theory is not true. And this is very important in the way we look to things. So it takes time to prove a theory. You know, Albert Einstein stated that time is a relative concept, and the higher you live above the sea level, the faster you should age. It's crazy theory. But it took 100 years to prove Einstein's theory to be true, and it's bad news if you own a penthouse. So in conclusion, we can say yes, ERAS can improve HPB surgery outcome. This is because if you do a proper implementation and auditing, you improve the outcome of the patient. If you change your practice and put an end of dogmas in surgery and perioperative care, you improve the patient outcome. You reinforce your teamwork with the ERAS program and you improve the outcome. You have better standardization of patient care and you have better outcome. And you have also the secular trend, and we know with time we improve our result. Thank you for your attention.
So I think we have 5 minutes for discussion. Can I maybe ask the speakers all to come to the floor? I'll go and stand over at the podium and help just kind of conduct the orchestra. But please just come to the microphones if you have some questions.
Oh, you go there and we come here. Okay.
We want to go. So there must be, are you all converts then? Everybody here has an ERAS program in their own hospital. I was actually very impressed by the last presentation by Mustapha. I mean, we actually, having analysed the data, looking at the level 1 evidence for all this multimodal approach to treatment, you're maybe talking about 3 or 4 elements that have got good level 1 evidence. So maybe just to the panel then, I mean, is the answer then just to focus on those areas where there is that level 1 evidence? Can we forget about all the other stuff and still deliver good results? Ollie?
Well, it seems to me that there's lots and lots of data out there from different parts of the world where people have been having different starting points, where their practice has been very different, and then they start to move towards putting all the elements in there. And it's absolutely clear in every one of those studies that the more of the elements you put in place, the better your outcomes are going to be. And depending on where your starting point is, and you look at which elements made the difference, they are going to differ. So it's very hard to say that, well, some are advocating you only need 1, 2, or 3, and that's going to solve the problem for you. But that's not true. It all depends on where your starting point is. So I think the more of the elements, the better. And also, when you look at the randomized trials and do the meta-analysis, this is very important. They are all different. So that means that the two groups that are being compared are going to be different in every study. So in essence, what the meta-analysis only shows is that the more of the elements that you put in place, the better your outcomes are going to be.
Okay. And Nicola, in Lausanne, I mean, you've gone back in 100 years. You stopped giving the champagne to the patients before their surgery. For you, then, what has been the success of the program in Lausanne?
Well, when we discussed first the ERAS protocol in Lausanne, I said to Ule, yes, but we are doing a lot of these ERAS elements, and probably we won't measure such a huge change. I was wrong, because it's exactly, I thought we were doing some stuff, but we were not following that thoroughly. And actually, our compliance to the protocol was between 25 and 40%. And then we looked at what we were really doing. So we did the stuff we thought we were doing, but really, and we increased our compliance to 75 to 80%. And we decreased our complication rate and our length of stay by 40%. I think one of the elements what is important is we use the expression best available evidence. And that's the point. We have missing a lot of level 1, but because it's very difficult to do a level 1. And in our department, we have done an analysis demonstrating that when you implement a colorectal protocol ERAS in your hospital, you have an impact on the non-ERAS patient from another specialty. Because the nurses are changing the way of working, you are changing your way of working, and the anesthesiologists do the same. So it's very difficult to make a prospective randomized study because you might bias the so-called control group.
Okay. Henry Pitter's got a question here.
I'll come back to the drain management issue because I think we still have lots of room to improve here. And there really is growing evidence in pancreatectomy that checking the amylase early is important, and a large percentage of people getting the drains out early is important. When we look at major hepatectomy, despite the randomized trials, in North America, 60% of surgeons are still using drains.
Oh, yes.
And they're not getting them out early, and they're not looking at whether there's any bile in the drain or not. We should be able to do the exact same thing after major hepatectomy with drains. For the people who are afraid to not use a drain, we should be able to figure out a way to check a bilirubin early and get the drains out early in a large percentage of patients. What do you all think?
I will tell you a story. When I arrived in Lausanne, the first 2 major hepatectomy I did without a drain, they needed a radiologic drain. So my colleagues were looking at me that way. But I made a presentation a long time ago in France, and I was quoting a study from a French hospital demonstrating that if you do not drain, you have less infected bilioma after. But you have the same number of bilioma, but they are less infected. So the conclusion of the study, we should not drain. And the resident came to me at the end of the presentation and said, you know what? We are still draining, despite the evidence. So dogma, dogma.
Yes, Ollie.
Just a quick comment on how we should do studies, because I think this is really essential. One of the problems with even the biggest randomized trials today, which is really the best evidence that we're building everything on today, is that many of them have a primary outcome which never shows any difference. And then people report on the secondary outcomes as if they were actually true. In fact, they are only hypothesis generating. And usually with big numbers, you can find some differences in these secondary outcomes. And that's what people take home as the message. If we're going to do this properly in the future, we need to have control over the elements that make a difference for the outcomes that we're actually looking for, not just the variable that we're changing between the two groups. And I think this is where we can do studies a lot better. And coming back to your question about drains or no drains, a trial of that, to answer that question, would need to have control over all the other elements that make a difference for the SSIs or whatever you're looking for.
Okay, so we have a question over here.
Do we have target urine output or the blood pressure management for first 24 and 48 hours after, say, major pancreatic resections?
I don't think we set targets in those terms. I think what's much more important is that you look at the whole patient. You're looking at other biomarkers such as lactate. We do central venous oxygen saturation. So I think looking at blood pressure alone is probably not terribly helpful.
Okay, we have maybe two final questions over here on the left-hand side. Yes.
Yeah, Lee from Hamburg. We are doing ERAS in pancreas surgery. Now we're starting liver. But I have some questions about how about complications after ERAS? Do you have any registries to see the complications in ERAS group? For example, lung emboli after low CVP and something like this. This first question. Second one is how to treat the bile leaks that are usually very difficult to drain, because we know that after, for example, perihelial creatinine tumor operation, we have 20 to 30% of bile leak. And these kind of patients, if we not drain, we have problem that after hepatic genostomy, too difficult to drain through a CT-guided plane. So I'm wondering how we can do for these specific populations.
Maybe Mustapha, do you want, or Nicola?
Well, for the drain that you put post-operatively by the radiology will replace the 90% of the drain you don't need. So this is not all the patient who will need a drain after a major hepatectomy. So about the data show it's about roughly 10% plus minus few percent. So there are some elements. Japanese colleagues are using ICG during the operation and an infrared camera to see if they have a bile duct leak during the operation. I think that's one of the major points we should do during the operation to decrease the future bile leak. And then if we have a bile leak, we will put a drain, but a percutaneous postoperative radiological drain. There is a difference in drain. You have the so-called prophylactic drain, just in case. So those are to be avoided. And then you have the therapeutic drains. And then we'll put the therapeutic drains, ARCP and all what we have to do. But I agree with you, it might be difficult to treat.
Is there a different bile leak rate? I think from...
No, it's not. We have not measured, and the data confirm that there are no difference in the bile leak rate. It's always about 10 to 15%.
So this is in liver surgery. There's different opinions. In patient with liver cirrhosis, there are less than 5% bile leak. If
Yes.
a patient have a biliary tumor, then have more than 20%. This is true. I think we should consider of in ERAS program.
You are right. There is a difference in the bile leak depending of the etiology of the liver basic disease. I agree with you, yes.
So I think we're going to come to the final question now behind you.
Yes, I think the crucial point is about trials. Because as you said, James, many, and Henry Pitt said it, many surgeons are not doing these things because they're unsure. So I would like the opinion of the panel. So there are places in the world where you have registries. So you have data on all the patients. You could do a randomized trial within the registry. Very simple. We have two options. Or we randomize only individual points, drain, no drain. Or we randomize routine, we do all a bit ERAS versus super strict ERAS. So we combine everything. Which of the two do you think is most relevant, the one we should do?
I think it's a very, very relevant question. I think in science or in medicine, it's not always yes or no. There is always a middle way, maybe is the best one. If we look for the drain in liver surgery, on the pancreas surgery, we have studies showing probably there is no difference. But in some patients, we need to drain. And I think we have to look also that if there is no difference between in liver in drain and no drain in bilioma, draining is not wrong if it is equal results, okay? And then you have to look on your facilities. If you are in a department where you have interventional radiology with easy access to the percutaneous drainage, so you can not drain the patient. But if you are in a hospital with no facilities for percutaneous drain, I think it's better to drain.
So
and then
I agree with that, but the point is not, I agree with everything you said.
Yeah.
But the point is, all the bits of ERAS are small and they count up to a big amount. But does the surgeon want to see one big trial definitely proving something about drains? No. Or the ERAS concept? Because in total, I think the ERAS concept is strong.
I think, yes, this is the second part I'm going to answer you. I think we have to look to both things. If we take one item, it will take long time to have the proof of the 37 item of the pancreas or 31 in the liver. It will take many decades to do it. And we have to look to the data from patient record. I think in the ERAS society, in the database, if we can collect several thousand of patients in liver surgery, in pancreatic surgery, I think we can get a very high level of evidence about the ERAS program. And the most important thing I believe is that it's a multidisciplinary. So we have to look to the whole process. It's not only one of the items which is important. It's the whole process, it's the teamwork. And this is, I think, in my belief, the most important thing is to look to the whole process and not each item.
So
and finally, if you do one study showing evidence that item 3 is excellent, we know it's not sufficient because each study, even randomized control studies, should be challenged 2 or 3 or 4 times to get the proof that it is really true.
Okay. So one final comment from Oliver.
Just a quick comment. If you want to test the concept of ERAS as a whole versus more traditional care, it's going to be very, very difficult because traditional care varies enormously in different places. And secondly, the only way that you could even try to address it would be by a cluster randomized trial where you have full control of it. And that's a huge undertaking. So I'm afraid we're probably not going to see that.
Okay. So on behalf of my co-chairman, Nicolas Desmartines, and on behalf of you, I'd like you to thank our speakers for having kept to time, kept to their remit and given us an entertaining session. Thank you very much.